She is on so she has an eminent knowledge on palliative care. Now she is in UK, but she is willing to teach palliative care. Her one of main that aim is to spread palliative care everywhere. So whenever we call her to teach palliative care, she is ready. So thank you, ma'am, for that. Welcome and over to you, ma'am.
Thank you very, very much. Big thank you to Almighty and thank you to Pallium too. It's a privilege and pleasure to be part of Pallium India. As I always say, I thank Pallium for accepting me. And the main aim of Pallium India is to spread and make sure palliative care service is available in every nook and corner of India. Why not Goa then? That's the main aim for us now. Next, okay? So hopefully in the next 45 minutes or so, I will take my level best effort to make sure all of you can understand what is palliative care and then get going with the whole course, enjoy, acquire knowledge and practice. Nice to see you, Arya, too. Hope you'll be happy to share my presentation from your end.
Yes, ma'am. Can you able to see the slides?
Yes. Thank you.
Okay, ma'am.
Okay, next slide, please. Okay, first thing, what is Pallium? That is what would have been running in the mind of all of you to know what it is. So we will go from the beginning. Basically, Pallium means, it's a Greek word and it means a cloak. So then we go on to the Oxford Dictionary meaning, what it is. That says to alleviate or relieve or mitigate. All mean the same. Alleviate suffering, relieve suffering, or mitigate suffering. These are all synonyms for the verbatim word. Next slide, please. So based on that is what we're going to go about today. Then why is that? Everyone is speaking about palliative care. Why? What happened suddenly? That is the next reason. So to understand that little bit more, we will go into the statistics. So in today, like many years ago, like 50, 100 years ago and all, what was the problem which was worrying the whole world were basic infections. But is that the issue now of today? No. In today's world, the main problem maker or the troublemaker are the non-communicable diseases. What are they? Examples are cancer, dementia, renal failure, any system failure you can take. And that too, it's gone to numbers which are unimaginable. So they've estimated that 1.5 billion people experience some form of chronic issue in the world. And in that, like a large number, 50 to 60 million, are said to be in the low and middle income population of the world, which is big numbers. And that is causing serious health related suffering. So, as I was mentioning about what alleviate means, alleviate any serious health related suffering. That is the meaning for palliative care. And why not? That should be one of the duty of any medical professional. Okay. So, and because the number is so high and they are needing some long-term care, the importance of palliative care to be understood and practiced has increased all over the world. And so another important factor is this is the reason or this is the statistical significance. Next, something also has to be understood. One important factor, which is just the previous slide, please. That death is inevitable, which cannot be avoided. But at the same time, in today's world, the importance has also shifted to something called as quality of life. What is that? So we all want to have a good quality of life all through, from young to old. So why not follow the same and continue till that itself, till the last breath? So that also is one of the important significance to understand what is death and to, at the end of it, accept death as something inevitable and render care till the last breath. That is one of the important things. So by doing that, how can we render this service? So that also is part of palliative care. Next slide, please. So what are all the things that we are going to try to do with that? So provide active total care for whoever is having a disease which is incurable. Next, control the symptoms to the maximum extent possible. Next, as I've been telling, quality, to provide best possible quality of life for patients. And not only for the patient, to the carers and families too. So this is the main important thing. So that is what we're going to see in the definition also. So it's a long, big definition. So just I've highlighted few important things. As I've been telling, what it all includes is provide quality of life of patients and families, as we have been telling, and for whom? To or anyone who has life-threatening or life-limiting illness. So life-threatening, for example, you can take oncology or any cancer patient for that. Life-limiting can be anyone with any long-term system failure, like renal failure, cardiac failure. You can put all system, respiratory failure, anything, neurological, dementia is an example. We'll go about in depth of all these as we move forward. And again, whether this could be these illnesses I'm telling, they can have physical issues, psychological issues, social issues, or spiritual issues. All components have to be looked into. And last but not the least, the quality of life of carers. Who is looking after them? Should we not care for them too? And improve quality of life for the patient and the carer. So for the patient and family. The carer can be a family member or a non-family member too. So to provide the best service to the patient and the carers, that is the meaning. So another important thing to be understood, the carer of family is also included in the definition itself. Next slide, please. So whenever someone is not well, see the first part of the picture, you see the patient is not well. When the patient is not well, his own, the person who loves him, kith or kin, spouse, children, anyone who is always with him also goes through the problem. So this picture is not something strange or alien to any of you. As we have been told, no, all of you are practicing nurses. You would have seen this day in, day out. But just we are highlighting it to know that the patient, or what I've been telling so long, it includes both. It could be anyone who is close to him or him or her looking after. So to have that in mind, why am I screaming patient, family, patient, family? Yes, that has significance. I need not say, all of you know that. So we are just enhancing or reiterating the facts. That's all. Next slide. Now we'll do a little bit about the history. How did this all get started? So it was Dame Cicely Saunders from the United Kingdom in the 1950s who was caring for patients. She was basically a nurse who was looking after patients who were nearly dying. But she had a lot of issues managing them and getting to a place where the services could be provided well for them. And then she was having so many barriers. So then she herself became a doctor and started practicing from the 60s. And then slowly, she is the founder for palliative care. And then from the United States, a psychiatrist called Elizabeth Kubler-Ross, she also did a lot of work by releasing books on death and dying. Okay, and she also is the person who has staged grief in such great extent so that everyone could understand and realize and do something for it. And next person who is well known in the history of palliative care is Balfour from Canada, who coined the word palliative care. And then from the early 2000s, palliative care has become a separate specialty so that everyone is able to know, study, and move forward. So, not only internationally, in India also, very many changes have happened. And what are they? There are recognized institutions which are having palliative care as a specialty. So, doctors, nurses, everyone could study that as a specialty. And the latest is that in the basic curriculum for doctors and nurses, also palliative care has become part of the curriculum. So if something becomes part of the curriculum, so everyone will start learning and knowing about it. So then spreading palliative care is not going to be difficult. So that is an important thing. Everyone should know at least something about palliative care before they finish, graduate, and become a part of the medical profession. So that is where we are today. So it's worth knowing from where to where we have come, and with that in mind, we can move forward. Next slide. Next comes an important thing, that everyone has some views and opinions. Are they right or are they myths? What has to be done? Next slide. So is palliative care only for cancer patients and AIDS patients? Can you all either answer in the chat? What is your opinion? Do you think palliative care is for cancer patients and AIDS patients only? From what I've said so far, what do you think? Thank you. So it's no. Very good. At least people are immediately, everyone is active, alert, and listening. Thank you. Thank you. So you have already said no, it's not. So next slide. So that's not the case. Is it only for end of life care? What is your thought for that? No. Okay. So that's what. So these are the two myths which has been very, very strongly impregnated into everyone's idea or thought. So the first thing is that it is just not only for end of life care, and it is not only for cancer and AIDS patients. So next slide. We will know that in more depth as we go about. Next, where can you provide palliative care? It can be done at home and it can be done in the hospital also. So we'll see a little bit about it now, and then we'll go in depth as we go further down the presentation. So it can be provided at both places, and both places have their own benefits, merits and demerits by doing it also. So it's that another important factor is that for you all to understand that both places you can provide palliative care. It's not that, oh, I can do here only, I cannot do there, nothing like that. As long as we are willing to do it, it can be done. Next slide, please. So what is the thing when it reaches home? Because here I've got this picture. Many part, not to every part of the world has urban and rural areas. Okay, so is there any rule that only whoever lives here can get it, whoever lives there cannot get? That is not the right way forward. And also we all know certain diseases, when it gets to a stage, it might make the person unable to access or reach the hospital. So for that, we have got pictures like from Pallium. We go to places where many times the house will be in a place where a fit and well person itself will find it difficult to go or reach. How will a patient who cannot walk comfortably or in such condition, how will they be able to come out of that place and access the medical cell? So the home care service is something which will help, and why not that patient should, that's what we are telling, no, to reach, to make sure that the service reaches whoever needs it when they need it, Not when it's not required. If you provide, is there any benefit out of it? No. So to understand that and then provide is what is required. Next slide. Then, to whom? Who is there any? What is the rule that who gets palliative care? So, as we said, anyone who has serious health related suffering. Okay. So, as we said, life limiting, life threatening, anything. We'll see little bit in more detail about. Next slide, please. So, for this, you could say that. Next slide, please. Broadly, you can just broadly classify it as anyone who has oncological issues. So it could be oncology is cancer. So anyone who has been diagnosed with cancer from stage 1 to stage 4. There's no rule that only this patient can get, that patient cannot get. So anyone who has any cancer related health issues. Okay. So is that means that only for cancer? No, it can be provided to non-oncology also. I'll give you a few examples for non-oncology. Any long-term system disease, chronic lung disease, COPD, interstitial lung disease, anyone who has long-term breathlessness due to the disease. So the disease has become so progressive that they are unable to do their daily activities of their living, ADLs. Okay, so I gave an example for respiratory. It could be a cardiovascular, congestive heart failure, then renal failure, end-stage renal disease, being on dialysis 3 times a day. We have so many patients in India. Every state has a big number, not 1, 2, in hundreds, thousands. 10,000 people are on renal dialysis 3 times a week. Okay, so there are so many things like that happening. So I can name that each system. So we have said cardiovascular, respiratory, renal, neurology, dementia is increasing in numbers like anything. Vascular dementia is another important thing. So those, everyone, as I've said, in both categories, so there's no difference. Only this patient gets and that patient doesn't get, nothing like that. So both need. So both can be provided. Next slide, please. So coming to what we need to have some aim or principles when we start or move about with it. So first, identify the symptoms and provide appropriate management. See, because as I said about myths, there are the professional barriers also have to be broken. Disease correction also is done. Not that, as I said, no, like still people believe, oh, palliative care, they may not do anything. No, that's not the fact and figures. Disease correction to the extent possible. Correct the correctable. You will be listening to this word again and again. Okay, that is the aim of our profession. We will try to correct and rectify symptoms if they are correctable to the maximum extent possible. Okay, so disease correction, if possible, if and when possible, we will have to correct, because that is the aim or that's our basic duty. Okay, next is you also have to do psychosocial assessment and management. So I'm a doctor, I will not do that. No, you have to get the appropriate person who can do it with your team and do that also. And these last 2 aspects, end of life care is also part of palliative care. Okay, if hospice care is needed, that also has to be provided. If terminal care is needed, that also has to be provided. So the myth was it was only for that. No, we will do what is palliative care and include these also into the armamentarium of palliative care itself. So that is the important thing to be understood. Next slide, please. So these are few things. See, this previous slide and this slide are very, very strong facts and figures. But if it is made simple and clear, it's not rocket science. Okay. So this next few points, neither hasten nor postpone death. Okay, I'm going to read that again. Neither hasten nor postpone death. What does that mean? Because that is what is the myth. Again, we are not speeding up death. At the same time, you have got no right to postpone death also. Death is a natural process. You don't try to meddle and mess with it. Okay? And provide pain relief from any symptom. Pain relief or symptom control, symptom relief is the important thing which has to be provided till the last breath. Why should someone be in pain if that is also part of your duty? I will do this, I will not do that. That's not, I will do whatever I have to do properly. Okay, and integrate psychosocial and spiritual aspects of patient care as all in one. Only then it will be complete. So these two slides, what we have said, these are all duties. Again, all these are basic duties which we cannot say no to it. If we don't do any of this, that is, we are not, we are not right. We can be penalized for all this. So basically, doing our duty in the right way is important. So just a minute. So far, am I too fast or is it okay? Just anyone, you could just type in the chat that anyone has any doubts or things to ask, or is it okay so far? Just let me know before we move forward. Okay, thank you. So next thing is that as I said, few more points. We have, it affirms life and regards dying as a normal process. Exactly. You give respect for life, and dying is also a natural process. So if you impart the knowledge, that is awareness. See, raising awareness is also part of our job. Okay, you're going to go do something. If you explain things very well, your life is made easy and they are also very happy. Why are they worried? Because they don't know. If you say things clearly, even this is in your day-to-day life. I'll give a simple example. You explain things, yeah, with your friend, someone at work or someone at home, how the matter goes on. Or if you don't tell anything, oh, if you had told, well, I wouldn't have argued at all. These are statements which you will be listening day in, day out. So that is an important thing. And then offer support system for patient until death. The main problem is that when something is, some cure or something is not possible, oh, nothing can be done further. Yes, nothing can be done to cure the disease, but to provide care for the patient, that can be provided until death. Why not only until death, until further on for the family also, which we will see. So this, in the way you explain to them, yes, unfortunately, cure option is not possible because of the disease per se, but care can be provided. We are willing to provide the care for you. So if you tell that, what is that the patient or family wants to know is some support system for them. The word that you will assure, the word that you say that you will be able to be with them, some form of support is there, you can reach me. So that is what they are looking for. So, and the same thing, you support the family with the patient's illness and in bereavement too. So these are the core principles of palliative care, which needs to be kept in mind. Next slide, please. Next is the important thing. When should this be provided? Next slide. So this graph is again, like it's a picture. See, any pictorial representation, we will all remember very well. So for this, I'm going to tell you, just take you a little bit out of the picture. All of us are very good movie watchers, okay? Let it be any part of our life. One poster we see and we can tell stories. How? Why? Because what the eye sees, it registers very well and retains also. So we have to pick up and use whatever are the capacities or abilities that anyone has. Why not use it well? So the same thing only. Anything given as a picture, you will remember very well. And that to add color to it, that's it. So all of you, I would say, take like a take-home thing will be this one. See, if you see this slide, it starts off with screening, where you have the green, where the screening may go on for some time. See, for example, someone is unwell for 2 months, not knowing what it is. So they have started investigation. So first one test, two tests, five tests, it goes on. So when the screening is happening and the diagnosis is, they are coming to get to the diagnosis. At that stage itself, palliative care and curative care. See, you can see the blue part is palliative care and the yellow part is curative care. Both, only thing is that palliative care and curative care can go hand in hand. If it goes hand in hand, it is benefit both for the patient and the service provider. Okay, so this is happening already in many parts of the world and in India too, where only thing, no, awareness again. Awareness is there. Then manpower. You're all getting trained now. So far, no one was there. So once people are trained, they can have a service also which can work hand in hand. So when, for example, when some patient is coming for treatment, I'll give an example, like examples what have happened really, no imaginative. For example, you all heard that when I worked in Adair Cancer Institute, it's a very big tertiary center. People from Assam to Kanyakumari, everywhere will come because that was it was basically an oncology unit. It's a very big center. So we will get patients who will be getting their diagnosis in the process. From that stage itself, I've seen patients. So, see, in any place working as a team, there is no I in team. What does that mean? So when you work together, you get the best benefit. So you're helping. So for example, oncology department may be having highest load. They can't provide everything. So if they combine with the palliative care team, so they will provide whatever is possible. Symptom management can be started from day one from there. So when you see that in the picture, at this stage of diagnosis, patient is going to have chemotherapy, radiotherapy, and see how the disease progresses. So during chemotherapy, radiotherapy, they may have pain, they may have vomiting. All I'm telling very simple. They may have other issues also. So they will let the curative team provide curative care, and the palliative care can provide supportive care. So when the disease treatment is going on itself will go. See, initially the yellow part is having a bigger role to play. So the curative team has a bigger role to play. Palliative care team, see, is having a smaller role. Okay, this is all, we look at all options. If the curative care goes very well, patient gets better, very good. Palliative care teamwork will come down and it can go on like that for some time. But unfortunately, the disease did not respond well. Okay, so then the curative care team role reduces and the palliative care role increases. So that is how it is. So you go with the flow of the disease progression and the patient response. Then if the, as I said, if the palliative care role increases, then it goes on to terminal care, end of life care. These are all terms which are used based on the duration, how long, for months, yeah, like for if the disease progresses and then it's got to a stage where the patient is getting deteriorating. So it then goes on to terminal care, and then finally it might get to few days and weeks when it goes on to end of life care. Okay, when no, see, any treatment given, the patient is not responding. So then finally it may go on to a stage of death of the patient. Okay, and see, after that also bereavement care is also part of palliative care. So see, from this light green to the dark green, the whole is palliative care. Okay, so the what to say, the horizontal axis is the course of the illness, and then the vertical one is the service provision. Okay, so this is what is palliative care. So where do you, when do you do? We have seen everything. For whom? all questions. See, these standard questions, no, have to be answered. Anything you take, where, why, what, how. So not only for this, in your day-to-day life also you take that and put that into practice, you will all find proper solutions for what is needed. So this is what when is important. So because this is one of the query. The myth was only end of life care. So is that the answer now? Or what I've taken you through, or this picture makes sense? So that is what. So whatever queries you have, doubts you have, they all have to be clarified. So this is one of the important things to be kept in mind. So from where to where, and in every aspect of it, palliative care has a role. So is that clear? Does anyone want me to go through this slide once again, or is that clear? Very good. Thank you very much. The next slide, please. Next, another important word is total care. So, see, suffering can be, as I said, no, I was telling psychosocial. For example, if someone is having diagnosed, we'll take simple, diagnosed with cancer. It's a patient, some 40-year-old who has wife, 3 children. He was the breadwinner of the family. Suddenly he cannot go to work. Children are all going to school. Wife is a homemaker. So what all will be going through in that person's mind? The disease per se is there. Is that only the problem? So the suffering could be a physical suffering, emotional suffering. See, I cannot go to work. How it is affecting me personally. I am drained. I cannot do anything. Then how will I face? How will I look after my wife and children? Who will look after them? Will they not be able to go to school from next month? Will they not be able to have food at home? Why God has punished me like this? What did I do wrong? I did something when I was young, so that is why I am getting punished. So all these will be going in any person who is having these type of situations, because life threatening, life limiting, it's changing one person's life. Still yesterday I was doing everything, today I cannot do. So this, it is just not pain or breathlessness or vomiting alone. All these also, that is why we said in the definition itself, it could be physical, psychosocial, emotional, or spiritual. It is only when you provide care in all, or you look into all these aspects, only then it is you're covering everything. That is when you're providing total care. If I just look after pain alone and ignore all that, will the person get better, or will the family as a whole find any solace or improvement? See, just these situations, put yourself, it's normally there's a standard statement, put yourself in their shoes. What does that mean? Think about their condition and see what is that would be best for them. So those are also to be kept in mind. So everything only if it is touched and covered, then the whatever you're doing is complete. So basically, nurse forms an important part of the team. Generally itself, a doctor, nurse, and a social worker. These are the basic 3 components who are needed to provide any simple service also. Why the team should have all these 3? So that one person is not overworked. See, only when someone is overworked, then burnout, I cannot manage, I don't want to manage. So you start something, when you start something itself, if you do it properly, it will sustain. You start something and do you want to fail immediately? Nobody wants to fail and nobody needs to fail. Only when you don't know what is to be done, you fail. So complete care provision is the requisite. That is what everyone has to understand. Then we'll see how to do that. Okay. So this all 4 components are essential, and you have to look into that to be able to provide good service. Next slide. Some of the common things are pain and breathlessness are very important symptoms, and you will see through, like, you're going to have 18 sessions now, how these two, because why I put these two is nearly 80% of the patients will come with one or the other, and you will come to know how you can manage them appropriately, because any symptom management is what, if you alleviate the symptom, the person is going to feel so much better, and they can do things for themselves. So these things you'll have to see to believe. Okay. And then that is our basic role to provide. So that is why I've just brought this up. So that helps them to improve. It improves quality of life, and that is our main duty, to do that and give them the best available benefit. Next slide. So we'll just see few important pluses of each hospital-based care and home-based care. See, in hospital-based care, you can have, as I said, no psychologist, social worker, everyone. You will have a full variety, multidisciplinary team may be there. You will find a multidisciplinary team in the hospital. So as I said, you will have all specialists. And even from nurses, no, every care cannot be provided at home, but those specialist services can be provided, and all of them are under one roof. You get to one place, you go to room or different departments, but everything is under one roof. That is when hospital-based care is provided. That is the plus point. So next slide. So what happens when it is done home-based? Only thing, you need to have a full team. As I said, whenever you're going to see patients like this, you have to train a team. Train like this, as what all of you are doing, training nurses, doctors, social workers, physiotherapists, volunteers. You get a full team trained, and then what is provided in hospital can be provided at home too. Only thing, resource and training are important. So once you make a team, then the same what is provided in hospital can be provided at home also. The initial effort has to be made. Then we'll see what are the pluses from the patient and carer point of view when the service is provided at home. Next slide. So these are the few things what people have said and felt. Okay. From patient's perspective, if you see, there is peace of mind, because the environment where the person is going to be is his own home. Is anyone happy staying in hospital? They won't allow my wife to come in, or it's not my bed. Okay, it's not my place where I'm used to. And I cannot have my kith and kin close to me. And they have confidence that when things are done at home, oh, this can be done at home. So if it could be done at home, that will be the best for me. These are from the patient's point of view. From carer's point of view, if I can provide the service for my loved one, what more? So I will find ways and means of managing, but still I would love to do. Then all the physical, financial, all those aspects are also looked into. And if it is done like that, you empower. The only thing here, what you need is you have to raise awareness and educate the carers. These are two important things. Raise awareness, educate, and train the carers to do. And in the duration of your course, you will be coming to know how many things you can do at home. Not that everything has to be bought from a shop. Okay, which you will, I don't want to break all the secrets on day one. Okay, you will know more and more. So many things can be done at home. You can save money you can teach the patients to save money and use that money instead of spending for the medical care for their daily living. They can have better food. So everything can be taught, and so only thing, little bit more of effort and time has to be put on that. Next slide. So rehabilitation. So that is also part of our job. As I said, no, like social, psychological. The story what I was telling, no, if that person is not going to be able to go to work, what can his wife homemaker can do? We can get very many things of these done and make some ways for their income. So everything has to be kept in mind. Only if you start thinking, you will start working. What the mind does not know, the hands or the eyes or nothing will do. So you have to start thinking, look into options, then put it into practice. Next slide. So these are all just clues for you to do. Next is, what all roles can all of you do? Are you only nurse or only caregiver? You can be a health educator. As I've said through, you educate the person who has the illness and the family. You can provide, you can be a counselor. You are going to be the person who is going to be listening to the patient's story. So you could act as a counselor. You could be a messenger too, conveying what the patient, all psychosocial issues. You can pick up things when the patient conveys. Take it to the psychosocial department and think and help in convey to them, and then they can find ways and means of overcoming it. Next thing is that you have to be an advocate. What the patient wants, that is what has to be done. So none of these roles are simple. These are all prestigious roles. Why not? If you can do it, why should you not do it? So think of everything. See, I'll give a simple example. The same person is a mother, same person is, you're a nurse, 9 to 5. Mother before 9, after 5. Then you could do many, many roles. Maybe a chauffeur for your children. Why not? You're doing so many roles. So similarly, do these roles also and be efficient in rendering what you could do. Next slide. Thank you very much. Anything anybody wants me to explain, I'm willing to do. Over to you, Shiba.
Thank you, ma'am, for the wonderful session. Anybody have any doubts or any comments, please ask.
You can unmute and speak also, or type
If
in the
you want,
chat.
you can, unmute and talk, or you can put your questions in the chat box too. Please try to clarify your doubts here. So this is our first session. You have to thorough in palliative care today itself.
Don't have any fear, okay? And you even simple doubt. Oh, what will they think about me? No, this is the platform. Better to clarify, not to see patient and suddenly have any doubt. That is most difficult, okay? And none of us need to go through that. Any doubt or queries you have, feel free to ask. And not only for today, this is the platform where you're having all like-minded people here. Utilize it. Okay, so that is something which will be very helpful. And you've got a good, even though all of you are from Goa, you might have known everyone, you might not have known. So you've got more 95, 90 plus people, friends too today, who are going to be with you. So utilize the opportunity and obtain the maximum knowledge that you could. Even cases and personal experiences, what are going to be shared, are also another important things which will increase your knowledge.
I hope your presentation is clear to everyone. They all understand well. So, before moving on to the case presentation, I would like to highlight few things. Madam has covered almost all the part, but for nurses, we have to keep it in mind one thing all the time. So, why they are come to us? Why the patients come to us? That is very very important. When someone get illness, any problems, they will try all non-medical things uh, first. So if that fails, they'll try to get medicine from the medical shop. So they this is usually happen, right? After that, that is also failed sometimes, then they will come to us. So what they are expecting from us, that is the thing you have to always remember. Why they are come to us? So they what they are expecting from us. So they are expecting from us a better care. So we all are nurses. We are spending more time with the patient, right? So we are the good persons, best person to assess, do the better assessment. We can able to find out the problems more, because if the patient is having physical, usually we all are focusing on the physical problems. So other than that, Madam has mentioned about that the total care aspects. What is total care? Physical, emotional, social, and spiritual. So these all are interconnected. Okay, if someone have physical problems, this, at the same time, if they have psychosocial issues, the physical distress will increase. So we have to give a special attention to that part also. We have to explore the psychosocial spiritual aspects too. If you are not able to explore that issues, your physical, that medications, if you try to give more medication for physical distress management, it won't help much. So that is my experience, my all my 18 years of experience, I learned this. We have to give a special attention to each area: physical, emotional, social, and spiritual. So total care is very very important. So how can we give total care? The main aim of palliative care is to improve the quality of life of the patient and their family. Okay, so the first day of the patient suffering, that just imagine a person diagnosed with a cancer. From the day first itself, the caregiver is also suffering with the patient, because they don't have any time to spend with the for their self care. They used to come with the patient. They used to sit with the patient. They used to stay with the patient. So they are the primary caregiver of the patient. So one thing you have to keep it in mind: without caregiver support, we can't do anything. We need to respect their the problems also. We have to respect them also. We have to see their suffering also. We have to listen their suffering also. So you learned palliative care is patient as well as the family. You have to give palliative care for patient and the family. And the another important thing is the second main aim is to relieve pain and other symptoms. If you are able to relieve their sufferings, like pain or any other symptoms, constipation, nausea, vomiting, any other symptom, if you can able to reduce their physical distress, definitely we can able to improve the quality of life. So try to reduce their sufferings. And the another important thing, teamwork. So that is very very important. We need a better team for providing good palliative care. So we need nurses, we need social officers, because if they have a lot of psychosocial issues there, we don't have any more time for spend and explore that problems. That time, if you have a social officer there, you can try to involve the social worker in that patient care, so that the social worker can explore that problems and she can able to help connect with the that maybe community people, or she can able to share that her things, because she is the persons in between us, no, between the patient and the medical team, so she can. And if the patients need a counseling, then if you have a psychologist, you can include psychologist. And if the patient is need a physiotherapy, definitely, if you have a physiotherapist there, you can involve the physiotherapist. So we need a teamwork. And finally, so we need an empathetic mind. See, if you have an empathetic mind there, what is empathy? Putting ourselves into their place. If you have an empathetic mind, definitely we do many things. Always we will think about from the patient side. If we are there, if my uncle is there, if my father is there, if my mother is there, if my sister is there, how can I act? So these kind of things we need. So we need an empathetic mind. So this is what palliative. You have to start, if possible, you have to start from the point of diagnosis. Ideal time to start palliative care is from the point of diagnosis, because along with the curative treatment, we can able to give a symptomatic management, so that they can able to continue the treatment without any problems, because we are there to support their symptoms. Because if they take a chemotherapy, just imagine what all side effects: nausea, vomiting, that stomatitis. These all from they are not able to swallow properly. That if you are not able to drink anything, dehydration. So these all things there. So if we are there, we can able to give something. Can give there, if they are not able to swallow properly, we can give a fluid, so that we can help the patient and ready for next chemo. So this is how palliative care works. So if we start palliative care along with the curative treatment, we can give a supportive care, and after that is a period of time. Definitely, the doctor will say like nothing more we can, but we are there. The palliative care are the palliative care teams are ready to take care of the patient. So we have to give a hope. We are here to take that to support you whenever you need. You have to come with us. You have to keep your door open all the time. So if there any problem there, they can come to you and take palliative care. So you can provide palliative care in outpatient clinic, through inpatient clinic, and home care services also. If they are able to come to your OPD, you can give OPD treatment. If they are not able to come to you, so then you have to think about home care facilities. So sometimes you are not able to control their symptoms in the home care settings. Then you have to think about the inpatient settings, not a long-term inpatient admissions. So you have to try to control their symptoms and educate the family members, that caregivers, and then send them back. So your home care team can able to do the follow. Okay, so this is how the palliative care is working. So how to keep it in mind all the time. I think we can, Madam, anything you want to add, or you can move on to the case presentation.
I think we have covered, no? So we'll go on to the case. Main thing is that to understand what it is, and then equip yourself and move forward. I think because it's a new thing for them, in due course, they will all pick up everything and be able to do. We can go ahead, Shiva.
Okay. So today I am going to present a patient story. This is a model case presentation. Actually, one of our nurses is planning to share this patient story today. Unfortunately, she is on leave today because of some health issues. So I am going to present this patient story. Next slide, please. So the next I am expecting, so please listen well. The next session onwards, one of you have to present a patient story based on the similar session, because the next session is on pain. You have to, one of you have to present a patient story on pain. So because after the theoretical presentation, we need a patient story for further discussion. So that's why we are planning to present a patient story. Okay. So this is my patient details. Mr. X, age 39-year-old male patient diagnosed with a traumatic aortic paralysis with stage 4 pressure sore on sacral region and left gluteal region. His presenting complaints was constipation 2 days, bed sore over sacral region and gluteal region, moderate pain over the hip region, urinary leakage. The history of illness was he had a history of fall while carrying weight followed by neck pain and weakness of both limbs, and was diagnosed with traumatic aortic paralysis in August 2015. And he had admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he developed a bed sore over the sacral and gluteal region, stage 4. History of pain over the hip region, wound site for more than 2 weeks, pain over the hip region. The pain score was 5 out of 10, intermittent burning type of pain, bilateral. Wound site, for the wound site, the score was 4 out of 10, continuous throbbing type of pain. So due to this, sometimes they keep that wound open. Disturbed sleep pattern and decreased oral intake. These are the history of the illness. And examination, at that admission time, he was conscious and oriented. The vital signs are normal, and systems also within normal limits. The physical problems, the main issue was pressure sore. The pressure sore, that area was warmth and tenderness. Exudates was present. Exudate means oozing out of discharge from the wound. Tunneling present, irregular in shape and foul smelling. Treatment and significant investigation, routine investigation done. All that investigations are normal. The results were normal. Next. Coming to the psychosocial aspects, 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately, not caring and not helping them. He was a manual laborer and was the breadwinner of his family. Now, he is not able to work. He is got paralysis. He is bedbound. Now his mother is a manual laborer and she is taking care of him. The main source of income is from mother's daily wages, her pension, and some of his friends' support. Have taken rupees 1.5 lakhs from the private finance bank for the treatment purpose. He has a devout Christian, now unable to go to church. This makes him very sad. So this is one of the spiritual issue. He communicates through cell phone. He says to his mother like, I don't think I can walk, so please don't spend money on my treatment. His main concern were pressure sore, pain, and financial problems. Coming to the summary, 39-year-old man with a traumatic artery with bedsore present over sacral and left gluteal region, stage 4, with pain over the hip region. Discussion points. The first question is, do we need to provide palliative care for this patient? So why I am highlighting this question here is, this is a non-cancer problem, so artery patient. So just think about that. Always we say it's like palliative care is for a cancer patient. Today's presentation, Madam has explained well. Palliative care is not only for cancer and AIDS; it's for non-cancer illness also. So the first question is, do we need to provide palliative care for this patient? The next question is, what are the problems faced by the patient? What all can be done for this patient and his mother? These are the questions. So we would like to hear from you all. Please unmute yourself and talk, or you can put your answers in the chat box. So Divya said we need to provide palliative care to him and to reduce suffering. Okay, very good. Any other opinion? Madam, over to you.
First, we will wait for them to say, and
Yes.
then we will jump in, I think.
Okay.
Yes, all of you, see, if someone wants to unmute and speak, also feel free. So first, is there someone who feels that we need not do anything for this patient? Just because he's telling that I don't want, so do we sit quiet? Some bed source needs to be treated. Someone has given an option of doing daily mass on YouTube. Yes, online options. Is there someone, as I was telling, feels that most of them are telling yes? Is there anyone who someone has different opinion? Because why I'm asking, if so, why? Or does everyone think that yes, we need to provide palliative care to him? Then we can see what are the problems faced by this patient. For that, maybe you can all think what you've had, the session that you've had, put that into perspective and try answering. Anyone can come forward, provide psychosocial support along with treatment of bedsore and pain. Yes, it is Divya.
Onto the psychosocial issues.
So you're covering all aspects. Many are telling, yes, we need to provide palliative care. So a little bit more like, as Divya said, can contact NGOs for finance. Exactly. That is where it comes. See, everything cannot be provided by one person and need not be also. Utilize, like you have to be someone who knows to approach and get support. I'll give a simple, there are people who need it and there are people who are willing to do it. Just link both of them. Demand, supply. Someone has got the demand, someone is willing to supply. So just connect the dots. See, look at the this screen, what has got the psychosocial aspects, no? Each one can be sorted out. A social worker or a person who is in that field will know. See, many times they are not aware what government grants and schemes are there. Does everyone know about it? Until a need comes, no one knows, because everyone has have got their own issues. Counseling has to be provided to patient and family, definitely. guess we've got good responses in the chat box.
Yes, ma'am.
Hmm. Providing, like, in this whole set of people who are there, is there anyone who is already having any type of palliative care service in any of your place where you're working? So, Sister Evelyn, is there a palliative care service in your place already, or so are there, like, in the government setup, do you have palliative care as like an outpatient, or at least a doctor or nurse already there doing that as part of their duty or routine duties? Anything like that exists, Shiba, there?
Yeah. So I think so most of them are new in palliative care. They don't
Okay,
have a, yeah,
okay.
palliative care, I think.
In
So
that case, at least they have all responded, like
yeah,
they've looked into all the aspects from what they've known from today.
yeah.
You can go ahead with the discussion, Shiba.
Okay, ma'am. Thank you. So definitely, as we discussed earlier, definitely this patient need palliative care because this is a life-limiting illness. So just imagine a person who is bedbound, not able to get up from the bed without support. So he was okay last week, and after that he met with this kind of accident, and then gradually the cautery paralysis is there. So this, just imagine, put yourself into that place and think always. Okay, so if even if he wants a cup of tea or cup of water, he needs to depend others. So his bowel and bladder, that sphincter control is out, and then incontinence will be there. So there are many problems, physical problems, because bedbound, we so he is a bedbound patient. Before discharge the patient from the hospital, it's our duty to teach the caregivers and patient about the importance of changing your position. So after that, this patient developed a pressure sore after discharge after 6 months. So because of the poor knowledge, they don't know what all things they need to do. So they don't know how to change it. His mother don't know how to change the sheets from the bed. So how to spread a new sheet? So he used to do that pull the sheet under the patient. So because of that, the patients can get pressure ulcer. So this patient need a good nursing care. So you have to give a proper education to his mother so that we can able to prevent pressure ulcer formation. Okay, so there are problems, physical problems, pressure sore and pain. So we were done a good assessment, and then based on the pain score and the type of pain, we treat well, and then now he is able to get up from the bed without support. Our physiotherapy team work worked hard, and then they will train them, and they are motivated him well, and then after that, before he went to hospital, he was able to get up from the bed without support. So we have to try to rehabilitate the patient. So physical rehabilitation is also important. And all at the same time, we have to think about the vocational rehabilitation and educational rehabilitation. So here, this patient is having physical issues. Definitely, we need to give a special attention to the physical part because pressure sore is there. Now he is no pressure sore. So now all pressure sore is healed, and he is a wheelchair patient. Now he is able to move without support, without depending others. He is able to move around. So that is the big thing. And for the spiritual problems, his main the spiritual distress was not able to go to church. So what shall we do for that? So what we did was we called the community members, we called his friends and motivated them, and they used to come to the patient home and take the patient out. So they need a diaper. Before moving out, they need to that wear a diaper because that is the only one thing they need. So that part we support. So then he was very happy. He was able to get out from the room and with the help of with help his friends, with the support of his friends. So so the community mobilization is also important. So try to connect with the NGOs or try to connect with the local community people or members, panchayat members, ASHA workers, something like that, so that they can able to help them. So this patient is the in the house all the time. So social isolation, family isolation is also there. So if possible, you can try to educate the caregivers. So try to find out the volunteers. If someone willing to that do some volunteer work there, you can train the volunteers, and if they get time, they can come go to this kind of patients, bedbound patients, and listen their problems so that they can able to explore it. If you have a psycho that problems, may the severe distress, what you usually do, you will find someone to explore your that problems. You will try to share your feeling to others, right? After that, how can what relief you got? Definitely, you will get a good mental relaxation after you sharing your distress to someone. So the same principle is here. If they are staying alone, if they are lying down alone, so the social isolation and family isolation will be there. So if possible, try to go there and be with the patient and listen their problems, and so that they can able to explore their problems. So if we can able to explore their problems, definitely we can able to help them. And the third question is, what all can be done for this patient and his mother? So, as I mentioned earlier, without caregiver support, we can't do anything. So we need her support because he is not married, not able to cook. She used to cook. Okay, so her health is also important. So he was the hypertensive patient. She was a hypertensive patient. So we used to do that give all medications. Now her that hypertension is under control. She is able to that do something for her family, and we provided a poultry farm also because our one of our that community volunteer is supported for that, and through that they will find some money for that so these kind of things you have to keep it in mind. Because of that we can able to improve their quality of life. If you think like that, definitely we can improve the quality of life. And if you are able to explore the problems well, if you do the proper assessment, definitely we can do many things for this patient and family. So anybody wants to add anything, any comments or anything You want to clarify? So I hope,
Just
yeah,
one thing, Shiva, as you said, just that came to my mind is respite care.
yeah.
Okay, what Shiva was mentioning is looking after the mother. Okay, you have to give that mother a break also. Okay, that is what is respite care. Because she is also a human being. If one of us are made to do something every day with a break, see, for example, take 7 days in a week, all of you want 1 day off, no? So does that mother not need that 1 day off? So just start thinking like that. That is respite care. Okay. So what can be done? How can it be done? Again, see, simple. I've all told you one trade secret. Put for everything the questions what I asked all of you. That's also okay for that mother. What needs to be done? Respite care. Okay, then how can I provide? Just give her 1 or 2 days break. So, for example, and there are friends who can are willing to help. You can ask the friends, can they really, they are taking him to touch her, is there someone, one friend who is happy to look after him for 2 days? See, I'm telling, giving you all options on how to do it. If there is a good lovely friend, well and good, or no, there's no friend, friend can take him to church but not look after him for 2 days, then look at, maybe is there a place like hospital or nursing home or somewhere where he can stay for 2 days so that the mother gets a 2 days break. So think parallelly. So this respite care, here it is the mother. Why I took this mother? Because that is what we are discussing. You look at things as the case comes to you. So how? Don't think, oh, friend is telling no, that's it, no other way out. Look at all other options. So like that, how can it be done? Where can it be done? Who can do it? So exactly these are the things. So then find out and just give the mother like 1 day off for all of you. You can give 1 day off for the mother. At least 1 day off, not every week. Once in 15 days. Or sometimes if there is like a nursing home or something where they are willing to have, see, again there is when you have to use charity, NGOs,
Something,
so many things are there who are willing to provide. Utilize these resources there and then start thinking. When you start thinking, you will find a way out, but you have to start thinking. So that is something to be kept. See, here it's the mother. It could be anyone. If it is a wife, if that wife also needs a break. That's it. Okay. Over to you, Shiva.
Okay, ma'am. Thank you. That's very, very important point, that respite care. So always you have to keep it in mind. So I hope all are clear about palliative care. We can wind up the session.
Radha ma'am,
Good
I
luck to all of you in the whole this full course. Enjoy. There, someone has raised their hands. Shiva, Vedashri.
Vedashree,
Do they
you
want to
want
ask
to,
anything?
Vedashree, are you there? Do you want to ask anything? No, ma'am. So I think
Okay.
accidentally.
Accidentally could be. Go ahead. Go ahead, Shiva.
Okay, ma'am. So we can wind up today's session. Thank you, ma'am, for the excellent presentation. They all are understand well about palliative care. Thank you, everyone, for your time and your active participation. So see you next time. Thank you.